Good evening and welcome to the Leukemia and Lymphoma Society of Canada's webcast called Children and Teenagers with Cancer, Cognitive and Emotional Challenges at School After Treatment. This presentation is part of a program to support all families affected by a blood cancer. Let's start the presentation. My name is Patricia Gilmore with the Leukemia and Lymphoma Society of Canada. I will be the host of this online event. During the webcast, you will hear only my voice and the speaker's voice. Since there are many of you on the line, questions may be asked at the end, but only using the chat function. The presentation will last 45 minutes and will be followed by a 15-minute question period. The presentation is being recorded and you'll be able to listen to it again on our website while following along with the PowerPoint. We will send you an email when everything is online in the coming days. Next slide, please. Our mission at the Leukemia and Lymphoma Society of Canada is to cure blood cancers and to improve the quality of life for patients and their families. We offer support to people affected by blood cancer every step of the way. Please be sure to reach out if need be. Next slide, please. We have several informative tools for children, parents, and school personnel on our new website, kidsgetbloodcancers.ca, including an animated video on leukemia. I would now like to introduce our speaker, Anne Klink, who has generously accepted to share her knowledge with us. Anne has a Master in Applied Science and is a psychological associate. Anne is the school liaison for the Pediatric Cancer School Support Program at the Children's Hospital London Health Sciences Centre. Over to you, Anne.
Thank you. So good evening. I'm honored to be speaking to all of you today, and I'd like to thank the Leukemia and Lymphoma Society for this opportunity. So I'm going to start just with a brief overview. And this webinar is, of course, about the cognitive and emotional issues at school after treatment, but sometimes the things we do during treatment can matter later. So I'd like to start there, if only briefly. We'll then shift to some of the issues after treatment, focusing first on cognitive challenges and then on emotional challenges. And I'll share what we know about who's at risk, what we can watch for, and what kind of supports might be helpful. I'll discuss how we can work together and describe a child's progress at school from diagnosis through to several years after treatment. I'll share a few advocacy tips for parents. I'm going to do my very best to do this concisely because I really want to be able to hear from you and hear your questions. So we know that there are many ways that childhood cancers are different from adult cancers. However, for the purposes of the discussion tonight, I believe this is the most important difference. Childhood cancer affects a developing child, so that means that childhood cancer and treatment have the potential to significantly interrupt a child's development. And as parents, healthcare professionals, and educators, it's our job to do what we can to minimize that potential interruption. And school is, of course, important for all children and plays a part in many aspects of their development. But for a child going through cancer treatment, continuing with education can be especially important. Not only do school activities provide normalcy during a time filled with change, school is future-focused, purposeful, and hopeful activity, and it can be a welcome distraction for many children and teens. And of course, school communities can provide social support to the child and family, either directly or indirectly. But there are many challenges to address to help a child continue with their education. So treatment demands, physical limitations, side effects, They all impact a child's ability to attend and participate. There may well be times when a child's too unwell to do any kind of school activities, even at home or in the hospital. There are emotional reactions. For example, children and teens may worry about keeping up with work or classmates' reactions. Parents may worry about their child's safety in the school environment. Teachers may wonder if they can support the child, and peers may worry about whether their friend will be okay and whether they too can get cancer. Also, because cancer is relatively rare in children and teens, there can be a knowledge and experience gap within many school communities. I could argue, I think, that this is true of the larger school system as well. So despite these challenges, and with good planning, many children and teens do attend school, at least some of the time during treatment, and most can continue with their education in some way. And ideally, the planning for that is a collaboration between the family, the school, and the treatment team. The level of support from your treatment center can vary. However, treatment centers should at the very least have some way of making information and resources about childhood cancer available to schools. Now, the most important elements of any plan are creativity and flexibility, because as some of you know firsthand, childhood cancer treatment can be unpredictable. As a result, planning can look somewhat like this. And we often get well beyond Plan C before we're done. So I'm not going to dwell on this list, except to point out a couple of things, because these can matter later. So figuring out how a child can continue with their academic and cognitive development, how social connections can be maintained, and developing good communication between the hospital, school, and family can all go a long way longer term. So moving on, first the good news. More than 85% of children diagnosed with cancer will survive the illness, so that's 7 out of 8 children who get cancer today will be long-term survivors. But there's a cost to that cure. It's estimated that 60% of childhood cancer survivors will have at least one long-term challenge related to the treatment they received. These are sometimes referred to as late effects. Today we'll be focusing on the cognitive, learning, and emotional challenges, but there are others as well. That scary list I just showed you is really a total compilation of all the possible late effects for all types of cancers combined, so a few cautions. Consult with the treatment team to understand any individual child's risk. Being at risk for something doesn't mean it will happen, but being aware of a risk allows us to monitor for problems and intervene early when necessary. And everything we know about long-term effects is, of course, learned from children treated in the past, and treatments change over time. So, for example, in the past, more children with acute lymphoblastic leukemia, or ALL, received cranial radiation, and higher doses of radiation were used than today. So then what children are at increased risk to have some cognitive and learning challenges? Well, some of these are treatment related. So these include radiation treatments to the brain, certain chemotherapy medications. And again, the dosage and the number of treatments matter or are factors in the risk. Not surprisingly, children who have brain tumors, brain surgery, or complications like stroke are more prone to later problems. And finally, children treated at a younger age are more vulnerable, which makes sense when you consider that there's a lot of brain development that's still yet to come. So who are these children? Most children are children treated for brain tumors, acute lymphoblastic leukemia, and non-Hodgkin's lymphomas. But to put this in perspective, when you look at the top 2 kinds of cancer that children get, they are ALL and brain tumors. And consider also that with ALL, more than half the time, children are diagnosed before the age of 5. But of course, there are many factors that may impact cognitive or learning abilities, and some are related to treatment and some are not. So for example, how does fatigue or steroid medications, how do those impact the ability to learn? What about the chemo brain or chemo fog that's often described by adult cancer patients? We're still learning what this is or what this isn't, and there's not a lot of information yet about how it affects younger people. There may be other treatment factors. For example, a child who receives vincristine may develop some fine motor issues, which if that happens during the time they're learning to print, that can be a factor. And treatment for some solid tumors often includes chemo that can cause hearing loss. Of course, in any group of children, some will have learning challenges, about 3 to 10%, just depending on what you read. And these kids miss a lot of school. But we also know some factors that may help with school success. Kids benefit when parents value education, read to them, or are involved in their child's school. We would presume that extra academic support or tutoring can help children develop skills. And just like there are children who have learning challenges, there are other children who start out ahead of the game. And at school, as in life, showing up matters. We know that attendance matters for all children. And for example, I just want to share a recent study that found that children who were chronically absent in kindergarten and grade 1 were over 3 times more likely to be behind in reading by grade 3. What did they mean by being chronically absent? So only 2 days a month on average. And I got to say, for a lot of the kids that I work with, chronic absence would be fantastic attendance. So what do we see at school? Well, many children, even many of those at risk, are doing just fine. They finish treatment, they slide back into school on a more regular basis, and are keep pace with their peers. In fact, sometimes I'm impressed at how some children are able to do that. And then there's another group of children who maybe are behind academically, but they're able to catch up. And I believe these are often just kids who've missed a lot of school. But there is a group that struggles. And it's important to note that even among children at risk, we can't say whether the problems are the result of treatment, the child would have had these problems anyway, or whether the problems are due to a combination of the treatment and other factors. In the end, though, I don't think it matters. They need support. So what do we see at school? We often see challenges with focus and attention and with working memory. And working memory is that ability to hold and manipulate information in your brain while you're solving something or doing something. And there's a lot of compelling research coming out showing that working memory is more predictive of academic success than IQ. You may have children who are able to do the work, but it takes them significantly longer. And you may have children who struggle with tasks, task demands, problem solving, or have trouble learning or remembering new skills. At home, you might see frustration about school, dropping grades, or notice your child isn't picking up information as quickly you would expect, or maybe not as quickly as their brothers and sisters did. You may have heard this term, executive functioning, and these are a set of processing skills that help us manage ourselves and our resources in order to achieve a goal. That's the technical definition. These are kind of some of the things that can be involved, and you'll notice there's quite a bit of overlap between some of the skills, some of the challenges I described on the previous page. And these type of skills seem to be particularly sensitive to treatment, and it is common to see weaknesses in at least some of them among children we assess. Also, these skills tend to develop later. I mean, you don't expect a 2-year-old to be able to do anything on this list, but by the later grades, They're a big part of a student's success. And I believe this is why we sometimes see children who do okay in the younger grades, but as these demands increase, they start to struggle. But I think it's really important to hear from those who are living the experience. And these are some quotes from people that I've worked with. So the parent who just says their child doesn't like school anymore. From a teacher, this is a lovely child, but she just kind of zones out sometimes. Too much homework and homework battles, always a red flag. Children who, even with support, aren't picking up on new skills and information. Does anybody know this kid? I think a lot of us know that kid. But if it's a chronic problem and persists with age, there may be a problem. And you might know this one as well. So this is that teen who can't keep track of her space, her time, or her stuff. So when do we consider a cognitive assessment? Well, children who have a very high risk of challenges, so children who have brain tumors, who are radiated, for example, would be in that really high risk category. They would ideally be offered assessment routinely. But for the rest, usually they should be seen if they've been back at school for a little while, behind academically, things aren't improving, and parents and teachers are seeing some evidence of difficulties in some of those processing areas that I talked about a few slides earlier. So an assessment looks at a variety of areas. The child would work one-on-one with an examiner and is asked to answer questions and perform various tasks. An assessment also includes information from interviews and questionnaires from teachers, parents, older children, and a review of other reports. And it kind of tries to get a big picture of the child's functioning. And in an ideal world, every child would have access to a timely assessment from their treatment center by a psychologist with a specialty in pediatric neuropsychology who has the expertise and experience in how a disease and treatment can affect the children. They know what it looks like and understand what these challenges mean in the short and longer term. I know that that's probably not the case for everywhere. Another option can be a psychoeducational assessment, which could be available through your treatment center or more commonly through the school system. And while these assessments use some of the same tests, they're sometimes much less detailed. So if a psychoeducational assessment outside of the hospital is kind of what's available for your child, it's really important to make sure the assessor is aware of your child's risks and the type of problems to look for. And sometimes it can help to ask for what kinds of tests, how many tests they use, because if it's just a few, it may not get at some of these processing challenges. And we know there are waiting lists for any publicly funded assessment. Well, I should also add that non-psychologists, psychoeducational assessments tend to be done by clinical psychologists or school psychology professionals. But non-psychologists can also provide some targeted assessment. So, for example, occupational therapists may assess fine motor skills, speech and language pathologists obviously assess language, and specialist teachers might administer formal tests of academic skills. Private assessment can be an option if it's available where you live, but it can be prohibitively expensive. And many families have already taken a financial hit during treatment. But if you have an extended health plan, it's worth checking to see if you have any coverage because it can vary quite significantly from really bad to actually quite good. I'm just going to skip by that in the interest of time. I was going to show you that's the Children's Oncology Group Guidelines for Long-Term Follow-Up, which you can find online. But generally, I think if we look at those as a gold standard, we're we're probably not doing a good job as a country in providing what kids need assessment-wise. So what do you get with an assessment other than a very long report? You should have a summary of the child's strengths and weaknesses relative to other children their age and information on a child learns, how they learn. There should be recommendations for helping at home and school, and it may result in a formal diagnosis or a formal identification at school. And this can help with special education planning. Now, except for Indigenous children living on reserve, education is a provincial responsibility in Canada, and that means that the regulations and terminology vary across the country. But wherever you are, generally, children have a right to an education, and children identified with special needs require programming to meet those needs. So this often takes the form of some kind of an individualized learning plan, and these have various names depending on where you are, so pick the one that fits. These plans should describe strengths and needs of a student, the programming and services and equipment that a child needs, indicate how, where, and by whom this will be provided. Should have clear objectives and strategies, and be developed with input from parents and children as they age. It should be a living document. It follows the child, it changes as the child develops and their needs change. What makes a good IEP? Well, there's probably people sitting in this audience tonight who know far more about writing IEPs than I do. And if you do some research, you'll find stuff like this. You know, the kinds of goals you should have, what they should be focused on, and there's lots of resources out there. But my favorite answer was given by an educational assistant. This comes from a blog by the late Lindsay Moyer. He was a longtime educator and advocate for children, and some people in Ontario might know of him. And this is what the EA said. It's a good IEP. It will be on the desk, wrinkled and coffee stained. All the bad ones are crisp, pristine, and in a file. So a good IEP is one that gets used. So I'd like to just briefly switch gears at this point and talk about some of the emotional challenges after treatment. And the first items on this list that I'm going to share relate to kind of what I would call sort of, quote, normal adjustment that many children and families face immediately or after treatment. And a lot of these are going to lessen or resolve over time. The fears about recurrence are natural and often more common in older children and parents rather than the younger ones. And the whole family needs to adjust to post-treatment life. Life shifts again. It no longer revolves around the treatment schedules, for example. And this also means there's less frequent and direct support available from the treatment team. And we always stress of all the challenges families face when their child is diagnosed, but I think it's important to acknowledge that completing treatment can also be pretty significant for some families. As a child returns to school, more often, or at all if they've been off for a while, children may start to worry about being behind. Teens especially may struggle with trying to reestablish their place in their peer group. And usually younger children who've constantly been with a parent may experience some separation anxiety as they return to school. A bigger concern, though, is a few children and parents who experience some post-traumatic stress symptoms related to their cancer experience. Other kids may experience social isolation, perhaps if they have trouble reintegrating back. They may participate in risk-taking behavior or even show evidence of some mental health challenges. So some more from the experts, starting with the best description I've ever heard of the angst that's associated with finishing treatment. And this mom told me, when my child got sick, it was like he was drowning and you threw him a life preserver. And now you're taking it away and seeing if he can swim. That's pretty terrifying if you think about it. This from a young teen girl really having trouble relating to her friends anymore and all the drama. And I think, sometimes these kids mature at a rate more faster than their friends, and they may find themselves needing to look for a different group. This from a young boy who's finding his peers maybe a little less sympathetic now that he's, technically better. And let's not forget about the siblings. I've heard this from more than one parent that sometimes that you think that the other children have handled things fairly well, and now that everybody takes a breather, you realize that maybe they haven't, or maybe they just didn't want to add a burden before, and now they feel they can. And finally, I think for some there's a realization that there will always be worries, especially for a child who has long-term challenges. It's not really over. But it's also important to note that while no family would choose to experience childhood cancer, many are able to find some positives in their experiences, and some people refer to this as post-traumatic growth. So some may find ways to give back. Others report that they appreciate life more and don't take things for granted. Many say they grew closer as a family. And many comment on finding out who was there for them and really valuing those friendships. So there are some risk factors that might increase the likelihood of emotional challenges after treatment. These are from the research. So being treated as a teen or being a girl, experiencing more intense treatment experiences like transplant, more traumatic kinds of things, maybe a trip to the critical care unit. And we know that children who have learning challenges in general are at risk for more at risk for emotional challenges, or children who have long-term physical challenges. Families who have less social support, or where there are underlying mental health or adjustment challenges before or during treatment, may be at more risk. And certain disease treatment factors, especially children with brain tumors. The majority of cancer survivors do not report emotional adjustment challenges in the longer term, and we see this in our aftercare clinic. Most of these kids are doing okay. In fact, in most studies, at least 2/3 report no concerns at all. And when you look at the rest of them, when you look at the number who have diagnosed mental health concerns, it's not that different from the general population. It tends to be a pretty resilient group for the most part. But when should you worry? Well, this list here will look familiar to anyone who works with children and teens. These are kind of signs of depression, anxiety, that sort of thing. And certainly these would be the post-traumatic stress symptoms that some children or parents even might experience. So this might be something like a child who's extremely anxious when coming for follow-up appointments, or who can't even cope with watching the Terry Fox video at school several years later, and has unwanted thoughts about their cancer experience. Again, as mentioned earlier, separation anxiety, or just starting to avoid school. I think the important thing when we're determining how big of a problem something is we have something that's lasting a while. It's not getting better, and it's interfering with daily life. So where do you find help? Well, it depends a little bit again on where you are and where you live, but a treatment team may be able to provide services or give you suggestions and resources or refer you to someone closer at home to home. And there may be services at school, especially if the problems are related to school and happening at school, you may be able to access some of those. There are, of course, services available through the health system and community-based services. And if you have deep pockets or a good extended health plan, there may be private options. And while I wouldn't recommend self-help approach for a more serious concern, there are resources that can help people with less severe challenges. For example, anxietycanada.com has some great resources that might help you support a child who maybe just runs a little bit on the anxious side. So in recent years, we've seen a greater awareness and thankfully less stigma about mental health challenges. But unfortunately, this hasn't translated into better or more timely services. So after treatment, communication and collaborative planning continues to be important. And over time, those relationships may shift. So for example, the treatment team may be less involved or less available depending on where you are. And parents and teachers may be working more closely together. So the approach that you take and the issues you address will depend on where you are in the reentry process. And the needs and issues will be quite different immediately after treatment, for example, because a child with ALL may have been attending school regularly for a couple of years, whereas a child with Burkitt's lymphoma or AML may have been completely unable to be at school, in which case the planning takes a different kind of approach. But regardless, parents need to ensure that schools are aware of their child's history, current needs, and risks. And you need to expect a learning curve. Most teachers aren't aware of potential late effects of treatment. And teachers, I think you need to appreciate that the treatment may be over, but the cancer experience continues. So do what you can to educate yourself. Know what to watch for. Also, it's important to find the balance. Remember, most of these children do well. So unless there are reasons to think otherwise, it's important to work towards setting regular expectations whenever possible. At the same time, though, we need to monitor for those potential problems, and it's really, really important to bring up concerns early. I've had some teachers tell me that they worry about burdening an overburdened family, but I've never heard a parent complain about learning about a problem earlier rather than later. And like I said, sometimes getting help involves a waiting list, so it's important to bring things up as they arise. So I'd like to tell you about Chloe, not her real name, of course. Now, there is a lot of information on these slides, so I'm going to just sort of speak to the highlights, kind of, especially in the early years. So Chloe, she's a typically developing little girl until her diagnosis with ALL at age 4. She just started school in Ontario. We have junior kindergarten, of course. And in addition to the usual treatment challenges, she had a few extras. She had quite a lot of muscle weaknesses in her hands that really affected her fine motor skills. And she spent a lot more time in a hospital than other kids, just lots of fever, neutropenia kind of episodes. She was somewhat more anxious than most children at the beginning, but she did respond well to extra support from the child life specialist. So at school, I have to say this school and family really worked well together. They were kind of a pleasure to work with, and the communication was amazing. So in junior kindergarten, she didn't attend very often. She was on a higher risk protocol, and that first year of treatment can be pretty busy. But she attended when she could, just for social reasons. And one lovely thing the teacher did was include her in the daily circle time via FaceTime whenever she was available. So in SK, she's still missing a lot of school, but certainly getting there more than she did. But there was a referral because of those fine motor issues to the school occupational therapist. And there weren't any major concerns about her readiness for grade 1 reported. This might have been because it's hard to evaluate a child that's only there a little more than half the time. So in grade 1, she completed half treatment about halfway through the school year. Her attendance improved. She formed friendships. But by the end of the year, she was still academically behind in everything. But to some extent, that was attributed to her absences at this point. So in grade 2, it's evident she's struggling in reading and writing. Her math seems to have caught up. They put some interventions to address the reading in place, and her reading does get better. In grade 3, as you can see, the attendance improves every year here. Teachers starting to see some minor difficulties with attention. Writing continues to be challenging, and some accommodations are put in place at school. And at this point, there's a referral made to the hospital neuropsychologist. Chloe loves grade 3, by the way. She's a wonderful teacher. Now in grade 4, things get a little harder. She struggles. She's complaining about stomach pain. There's no medical reason. She's unhappy. Homework's becoming a problem and a battle. Her teacher's reporting more significant attention issues. She's not finishing her work. Written language problems are, if anything, getting worse. And as often happens at this age, and quite naturally, the teacher's expecting a little more independence and organization. And she's still waiting for an assessment. But we do educate the teacher a little bit about her challenges. She finally gets an assessment, and this child has lots of strengths, lots of solid average skills. Does okay socially. She's got a good work ethic. But there are some challenges. Not surprisingly, the written language is well below grade level, and parents and teachers' ratings show some evidence of executive functioning challenges, and there are attention and working memory problems evident, as well as slow processing speed. And of concern, this is an anxious little girl. So what can we do for Chloe? Well, she's formally identified as having a learning disorder, or classified according to the regulations, learning disability student. And there's an individual plan developed for her. Sorry, I'm being Ontario-centric there. She qualifies for some equipment to help with the written language. There's a number of strategies put in place to help with the processing speed and with writing. The teacher adopts some challenges to help her with some of the attention some strategies to help her with the attention challenges. As she has a little bit this is major for this family. So they changed the homework routines at home, so they had a timer with built-in breaks, and the teacher not only prioritized the homework, but she gave her explicit permission to stop after a certain time period. A little bit of peer tutoring around using her planner, and a referral to some counseling services. So a year later, things were definitely better. The stomach ache stopped. She was using some relaxation techniques, actually, that her mom taught her, because, actually by the time they got in to see the counselor, things were pretty good. Her writing was and continues to be a struggle, but she's making progress and having some success with the technology, and that takes time to learn. It's not going to fix it immediately. The attention problems were manageable with strategies that the teacher is using. But it isn't always that neat and tidy, and it doesn't always work that way. And sometimes when you have a child with special needs, you may just shift from being a parent to being an advocate. And as Ms. Bowler in this quote points out, advocacy is an intellectual exercise, and it's a skill that takes time to develop. And parenting, on the other hand, as we know, can be pretty primal. And as parents, we have those mama and papa bear instincts. to protect our child. And sometimes it's hard to check those emotions at the door. So just a few tips. It's important to keep it proactive and positive. Do your homework. Build relationships early in the school year. Assume the best about teachers and thank them for what they do. We often go to teachers with complaints and not with compliments. Record keeping is important. You know that big file you kept when your child was on treatment? Well, if you have a child who has challenges, you might find you need another one. And I can't stress enough how important it is, even though it takes time, to put your concerns in writing. Because this not only helps you organize your thoughts, it makes it easier to remember and harder to ignore. And that rule of, writing something and then waiting till the next day before you hit the send button is always a good one. And meetings can be a little intimidating. It sometimes feels like you've been sent to the principal's office. So come prepared. Be organized, be focused, prioritize what's important. You're not going to fix everything at once. Focus on needs and be specific. So saying my child needs an educational assistant or a student aide, I'm not sure what you would call them. They probably have various names. But saying my child needs an educational assistant is not really specific, at least in terms of the child's needs. Saying something like my child needs one-to-one assistance in these specific situations because he has balance issues that make it unsafe for him otherwise. That's a very specific thing. Because the answer may not be an EA, and they may not have an EA, but they may be able to find another way to address those needs. Focus on solutions. Make suggestions, be open to other ideas, and follow up to make sure things happen the way they're supposed to happen. And here's a quote from a very frustrated parent of a special needs child talking about finding solutions. And as you can read, I've been to these meetings where the people around the table are focusing on what they can't do and making excuses for the resources they don't have, rather than putting the time and energy and resources into finding solutions. Because resources are limited, but that doesn't mean there aren't creative ways to solve most problems. When things get tough, sometimes it's good to call in reinforcements. Could be a health professional or a more assertive family member even. And sometimes, obviously your treatment team isn't next door, but there might be someone who's willing to be on the speakerphone during a meeting. And there are times when it's necessary to go over people's heads. You can be nice about it. You can let the people know you're doing it, and you can frame it in the way that we're not getting anywhere, and I just want to talk to the principal or whoever the next level in command is, to see if there's ideas we haven't considered. And it's important to go, just knowing from some experience of some of the parents I worked with, don't just go straight to the superintendent, because all he's going to do is send you back to the principal if you haven't already talked to the principal. Going forward, though, I think we have to remember that when we're dealing with children with any special needs, we often focus too much on the needs, often because that's what gets children the help. But we need to remember to focus on their strengths as well, and not to lose sight of the many wonderful qualities they have. And as children age, we need to work together to help them learn to be their own advocate. They need to use their own strengths, understand their challenges, and learn how to get what they need. And planning always matters, especially with a high needs child. Looking ahead to the next stages is important. So I'd like to close the presentation with a quote from Ross Greene. He's a psychologist who works with some pretty high needs kids, and he always says, kids do well if they can. Because doing well, he says, is always preferable to not doing well. And in fact, many of our cancer survivors do well. But children who struggle, they struggle when they lack the skills and supports that they need to do well. So if we can teach those skills and provide those supports, we can allow children to meet their full potential. And there are a few resources here. I'm just going to leave on the screen for a second about some of the things I talked about that might be helpful to you. And I believe it's time for questions.
Thank you, Anne, for helping us understand the challenges of a child back to school during or after their treatment. The Leukemia and Lymphoma Society will continue to do its part to support all families affected by blood cancer. Now we have opportunity to take some general questions. For anyone who would like to ask questions, you can please open up the chat panel on the bottom right-hand side of your screen and type your question there. We'll give a couple minutes for people to type in their questions, and Anne will be able to answer them one by one. So we have one question that has come in. Is there anything we can do right after a diagnosis to prevent cognitive problems in the future?
That's a good question. And part of the challenge is, it's a little bit on what treatment we're looking at. I think, though, if we know that our child has the potential to lag behind in academic development, and there are ways that we can continue to stimulate that academic development, I think that's really important, which is why, I think I always worry when the schools say to me early on, we're not going to worry about the school stuff, their health is more important. And it's like, yep, you're right. That's the first priority right now. But parents and children do worry about those problems. So having ways to keep that happening, whether that's, home instruction, hospital, school, just educational games and activities that keep kids stimulated, all those things are important. Yeah, I think that's the best I can give you on that one.
Okay, we have another question here. Thank you, Anne. My 11-year-old son is 3 years off treatment for ALL. He has learning disabilities and has been tested. He continues to have trouble with writing. Is this likely to improve, or should we focus on other means to write, such as typing, speech to text, etc.?
So you said he's 11 years old.
11 years old, 3 years off of treatment for ALL, and has learning disabilities and has been tested. He continues to have trouble with writing. Is this likely to improve, or should we focus on other means to write, such as typing, speech to text, etc.?
Yeah, there's two parts of that question, and one is, will it improve? And it may improve. It may not improve at a rate that keeps up with his peers, and he may not catch up per se. And because he's 11 years old, you got to think of the demands at school and what he's asked to do. So I think you could level the playing field a little bit by giving him some of the technology and working on those skills. And let's face it, we live in a society where pencil and paper is less and less important. So working on things like keyboarding, speech to text, can be really helpful for children. The one thing I would mention, though, is that this should seem obvious, but isn't always, unfortunately, is just giving a child the technology isn't enough. There needs to be the resources put into training the child on the technology, because there is a learning curve, and a child who has a learning disability may take a little more support. But I think in the long run, technology can, like I said, really level the playing field for children, and might be something, especially at this age, that you want to push for, because high school is not very far away, and those demands are only going to get more as time goes on.
Thank you, Anne. We have another question here from Amy. If a child does qualify for one-to-one EA, would it be best the child has a consistent person, or switching EAs around a lot during their day?
I mean, I think in an ideal world, a consistent person would be good. It might depend on the child, though. I mean, some child are more adaptable. Um, some EAs work better with a particular child. I think I think the problem though is that schools make decisions based on not just the needs of the child. They have staffing needs, other children's needs to address. So, well, it would be ideal. Whether you can push for that to happen, I don't know. Yeah. I think an anxious child might especially benefit from, that consistency, just because knowing what to expect is sometimes really important to anxious children.
Thank you, Anne. We have another question here from Lynn. My son is still on treatment for ALL. His grade 1 report cards indicate he is behind in reading and writing. Should I be asking for an assessment now or wait until we get further down the developmental road, i.e. grade 3?
That's one of those it depends questions. We certainly do have children that we refer for assessment while they're still on treatment. And it kind of depends on things like, where they are, especially if they're maybe on one of the very higher risk protocols where the risks might be a little greater, the nature of the problem, how much they've been at school. Are we still just seeing the effects of absenteeism? It's hard to say. It's also depends on where where you whether you're able to get an assessment at your treatment center or not. Because if you are, what you could do is talk to whoever they would refer you to at the treatment center and get their advice. With more information, they might be able to suggest the best timing for an assessment. If not, it might be, if you're looking at trying to get an assessment at school, those don't always come quickly. So maybe just starting to make a little bit of noise might mean that they do get it eventually, and maybe in a more timely manner. There's different policies at different school boards. Some do wait until a little later to test. Also, grade ones might be where sometimes it's what am I trying to say? Sometimes as children get a little older, the tests can be a little more accurate and they're more able to do some of the tests. So sometimes waiting just a little bit can be helpful. I know our neuropsychologist will see children younger than 6 if they're, major concerns or the information is needed to help with programming. But otherwise, she waits until at least 6 and sometimes a little bit longer. She also tends to wait until kids have had at least a decent stretch back at school, unless the problems are so severe that they're really causing problems and the information is really needed for programming. Waiting a little bit can sometimes be helpful. So I don't know how clear that was, but it does depend on a lot of factors.
Thank you, Anne. We have another question here from Marie. When the child has been assessed with severe delays, which is causing social isolation, and he's having anxiety going to school, will this improve as he progresses to school, and how do I ensure he's going to progress academically? I'm advocating, but there just doesn't seem to be enough resources to address his issues. He is 6 and just in kindergarten. He is currently on treatment and has a twin who he's struggling to reconnect with. How can I get him all the resources he needs without turning into that mom?
Yeah, we all want to try to not be that mom. And I think some of the advocacy tips that I did mention might be helpful for you if you're not doing those already. There was a lot of information there. So he's got delays. Could you just repeat some of that again, just to give me a
Yes. So So he is 6 and in kindergarten. He has been assessed with severe delays, which is causing social isolation, and he's having anxiety going to school. The first question, I guess, here is, will this improve as he progresses to school? And how do I ensure he's going to progress academically?
So I'm just writing this down so I can help me think a little bit. Um, hmm. I, and I guess part, you know, when they're little, it's hard to know if these are delays that are, you know, when children are treated for cancer, they have a very different childhood experience than the average child. So sometimes it's really hard to know, are some of the delays just because of lack of opportunity? Are some of the delays that the child would have had anyway, or are some of the delays because of the treatment? It's really hard to tease some of it out, because if the parts that are due to lack of opportunity certainly might improve, but if there's some true cognitive deficits, they may continue to struggle somewhat. Um, I think sounds a little bit like he's socially isolated, maybe because of the delays. So I'm not sure if talking to the teacher about how to address that piece might be helpful, or including him in other activities where there's opportunities for socialization. And I'm asking a lot when you're on treatment, because sometimes just getting them out the door to school is enough. I think as much as you can. Um, Complex question. I don't have all the information.
And you know what I would say also to Marie is that she can be in touch with the Leukemia and Lymphoma Society of Canada. We have many new resources available to parents and children who have undergone a recent diagnosis. So Marie, please feel free to reach out to us after the webcast, and we can put you in touch with your local region's community engagement manager to
and
help
and I and
through
I
all
think
the resources.
keep advocating. There's ways to do it so you won't become that mother. But you do, the old squeaky wheel does get the grease, and it could also just be that at his age, often there's less. Some of the other, they may not have quite as many resources for kindergarten. There's just because there's a lot of variability in development. So, but as time goes on, hopefully you can get him more support.
Thank you, Anne. We have another question here from Michelle. What has been the success rate for teaching teen peers about cancer on the return back to school? I would hate to see my 14-year-old feel more freakish going back to school.
Sorry, I'm just going to switch. Hello? Can you still hear me?
Yes, we hear you, Anne.
Great. Sorry, I just had one handset dying there, so I needed to switch. Sorry about the feedback that can have been.
Thank you.
Sorry. So the success rate of teens. Can you repeat the question for me?
Sure. There's a number of questions in Michelle's question, but I'll reiterate the first one, which is, what has been the success rate for teaching teen peers about cancer on the return back to school?
Okay. The research on school reintegration techniques is somewhat inadequate, I guess. But in my experience, one of the challenges for teaching teen peers, when a child returns to school, is that often the teens really have to be convinced it's a good idea. But I think it can be helpful. And with teens, though, with a grade 2 student, you're often talking to the child's classes. With teens, you're often asking the child to select the people that they want to know the most about their situation. What I've found helpful is sometimes, there's the piece with the kids where the more in-depth work is done with the kids who are actually directly involved, and then maybe just some very minimal work done by the teacher for classmates if it seems like it would be helpful for the class to know what's happening. But I think whenever you're dealing with teens, it's really, really important to have their buy-in and to have them be comfortable with what's happening because, um, they have so little control in this at a time when they're really trying to assert control that, it's really important to respect their wishes. But I have seen it be very helpful. There are other parts there?
Yeah, the second part to Michelle's question was, is PTSD about hospital visits a common thing? I have a 14-year-old who reads so much, but this is a real concern for her.
That she what so much?
Sorry, PTSD about hospital visits. And it says that she reads so much, but this is a real concern. I gather that Michelle's daughter has a lot of PSD about hospital visits. And is that common?
It's not overly common, but it certainly does happen for children. We have a few children who come to our aftercare clinic who still have major challenges getting through the door. But it can be a factor. It's usually not full blown PTSD. It may be, like I said, it tends to be more some of the symptoms, but they're not necessarily the severity where you'd have a diagnosis.
Okay, thank you, Anne. We have two more questions here. It's currently 7:30, so if anyone does have to leave, we'll just take the last two questions and then we'll conclude our webcast with two more slides. So a question here from Jen. My daughter is 5 years out of treatment. She is 10 years old. She does well in school, but we deal with issues at home, emotional issues at home. We've recently been seeking a clinical health psychologist and working with her on her emotions. Her outbursts only happen at home, and it has gotten worse over the years. Since we are only seeing emotional troubles at home, do we need to have her assessed again at school at some point? They had her assessed in kindergarten. So the question here is, do we need to have her assessed again at school if the majority of the issues, emotional issues, are appearing at home?
I think if everything's going okay at school otherwise, so if she's achieving well academically, if things are decent with friends, if schools, because there's two possibilities here, and one is that it's kind of surprising that the issues aren't impacting her at all at school. But the only thing you would want to be concerned about is sometimes you have a child who's struggling at school, but the problems only come out at home, and that's because they know that we love them no matter what, right? And they, I've seen kids hold it together all day and then come home. So I guess you'd want to that might be something that whoever's working with her could determine. If the source of the problems isn't at school and there don't appear to be any learning issues, I don't know if a reassessment would be needed. But it's worth exploring a little bit, perhaps with the person who is working with her.
So we have time for one last question here from Caitlin. Caitlin asks, can you speak more to social reintegration strategies for younger students? I teach a student in grade 5 who is 10 years old.
Okay. Well, so you're probably looking at a child who's been away for a while, and you're looking at having them come back. And I think it might depend on the situation and where you are in the treatment. But I think some things we can do is, if it makes sense and everybody thinks it's a good idea, it can be helpful to, before the child comes back, to make sure that the other students are aware of what's going on, age appropriate information. There's lots of resources for that, and I know including from the Leukemia and Lymphoma Society. Sometimes doing things, I think for children, keeping in touch with their peer group prior to that reentry can be really important. So think of ways, and there are some listed probably in your resources. I have some listed in our little book called it's called Helping Schools Cope with Childhood Cancer, which is available online. But ways to keep connected with that student and encourage other children to keep connected with that student. Because, if they've had that frequent contact with friends and regular contact with friends, I find that reentry often goes a lot better than if they've been away for a while. Because I think the longer they've been away, the more anxious they get. And if they're feeling some welcoming vibes happening, it can make things go a lot better.
Great. Thank you so much, Anne. If we could just go to the last slide.
I sure will.
We'd like to thank Janice Rotman for her support that made this webcast possible. Please, after the webcast, you will be sent an evaluation form. Please fill it out, as it will help us better meet your needs for future webcasts. You can also visit our website in case you'd like to find out more about our services and research program, and check our website regularly for the dates of our upcoming webcasts on lscanada.org/webcasts. Next slide, please. These are the two links to our microsite, kidsgetbloodcancers.ca, and our corporate site, lscanada.org. Thank you very much, Anne, for your time tonight, and thank you to everyone on the line who has stayed with us all the way through. We really appreciate your time tonight. Thank you for joining us, and have a great evening.
Thank you.
Thank you, Anne.